The committee be called to order. Myself and Mr. Deal are the first questioners, so we might as well get started, and then I'm sure the others will start coming in. So I'll recognize myself for 5 minutes. I wanted to ask Dr. Gawande the first questions. During the health summit, and I keep harking back to that, I know, the consensus, was clearly that we weren't looking to make radical changes with the system. We really were just looking to improve the current system. And I mean, politically, certainly that's going to be the easiest way to go. And of course, in my perspective, when we talk about the current system, I divide it into 3 parts. One are existing government programs like Medicare, Medicaid, SCHIP, and how we can improve those. And then the second thing would be employer-sponsored care, which I think Mr. Ebler stated, has been drastically reduced because of rising costs over the last few years. The percentage of Americans that get their health care through their employers is down. And then finally, of course, there's this idea of creating some kind of a health market or national, insurance pool that the government would regulate in some way, and either with totally private insurers or possibly with a government option. For those who now are, can't get a government program because they're not eligible or they don't get it through their employer and they have to go on the private market. So when I talk about building, on the current system, I mean, those are the kinds of things that I talk about. But, you say, I think, Dr. Gawande, you say that we can't simply expand coverage and leave it at that. In other words, we know that we hope that we can reduce costs and reduce growth and come up maybe with a new funding source, as the President has in his budget. But that's all part and parcel of the ability to expand coverage. In other words, we're going to hopefully expand coverage by using some of the cost savings. But if all we do is expand coverage, that's not going to be good enough. And I also wanted to hark back to what Mr. Ebler said, because I was thinking of my staff person in my office. You talked about how you said that with high levels of uninsurance may undermine health coverage for the insured population. And in the previous panel, I used the example of my staff person in New Jersey who has, I think, Blue Cross Blue Shield, works for me, but he couldn't get a primary care physician, so he ended up in an emergency room. So I guess my fear is, we want to build on the current system, we want to expand coverage, but at the same time, we've got to make sure that it's done in a way that improves the system and cuts and creates cost efficiency. So I guess I'd like to know, from Dr. Gawande, how do we achieve these goals? I mean, can you walk me briefly through and show how it's achievable to cover everyone and use cost savings to pay for a good percentage of it and still have a quality system? I mean, you could talk for days, but.
So the short answer is that it's going to happen on a path that takes a step-by-step process. So imagine on January 1, 2011, what can we do? Within weeks, we could cover an entire population of people. We could start with people under 25, for example, and have them in coverage by saying that we would enroll them in a plan, and it can build on the experiences we have. It could be one that is based on something like the federal employee benefits plans, which offer a range of private options. It could be an option that's a public option building off of Medicaid or Medicare. But that coverage part can be done. The second part of it is whether you are able to begin to include the kinds of proposals that people proposed earlier in the panel, in that first panel. Do you begin to include, for example, in Medicare and other kinds of programs, medical home and other models which start to make primary care better reimbursed and also just better organized? But we have work to do on our side in medicine as part of reform as well. And I think that includes being able to now test ways to structure care that make it more cost effective, but more important, better in safety and better in quality. So, for
Let me issue this, though, and I know
Yeah.
I'm trying to cut you off, but
no, please do.
include for me your opinion about whether this should be a public option and whether or not we should be expanding employer-sponsored care, for example, by providing tax credits or, making it more affordable through using federal dollars for that.
Well, the debate over the private-public option is a bit baffling to me. I think the question people are asking is whether the existence of a public choice undermines the ability of the private sector to succeed. And we live in a world that looks like that, as it is. We live in a world where we have Medicaid, we have the VA, we have Medicare, and we have private insurance. We have a kind of flotilla of ships that provide our healthcare system with a big gap because you got 15% dumped off of these ships into the sea without coverage. And so what we're talking about is what is the makeup of this ship that would be a lifeboat for the people who are left out. As a clinician, I don't have any strong preference about a private plan. Dealing with the private insurers is as ugly to me as dealing with Medicare. I have, just like Dr. Williamson laid out, I have a full-time person who has to manage just dealing with insurance rejections and referral numbers and everything else. And so I think a fundamental part of this is that we include research work for the practical know-how of cutting that insurance paperwork and that private insurance administrative cost for us down. I think there is a burden on that I see as both a citizen and as a physician, where I wonder what is the added value of paying more for some of those private insurance costs that I'm absorbing. And I do think there's a burden to prove that value in being able to coordinate care and improve the value of our end results.
Okay, thank you.
Well, this is a difficult onion to peel. First of all, I'd like to ask the two doctors here, both of whom are specialists. When we start talking about concepts like medical homes, obviously your practices depend on referrals from someone below you in the chain of delivery. Do you have concerns about medical homes becoming the proverbial gatekeepers that maybe absorb more responsibility than perhaps we would anticipate? Is that a concern?
That certainly was a concern, I think, back in the 90s. I think what we saw is that the gatekeeper model really didn't work for anyone. It added delays, it added extra costs. I do agree that anything that would serve as a gatekeeper function is concerning to specialists, and it should be concerning to patients. As I understand the medical home concept as it's been presented, it's not fundamentally a gatekeeper as that term was initially introduced. So yes, I'm concerned about any gatekeeper scenario, but my understanding of the medical home scenario as is being put forth now doesn't include that as a significant consideration.
Yeah, I would agree. The medical home concept, as I understand it, and it does shift a bit, but the general idea is that the only way the primary care physician is paid is if you are physically with the patient in your office, and compensating them for all that time they spend on the phone, on email, coordinating care with other specialists should be done, and that's a major part of what primary care physicians do, and we should make that more attractive and better structured. And I think that would make the specialty care better as well. The way I think of it is we should have a medical home, but there are going to be specialists in the neighborhood.
Well, I agree with the concept as long as it plays out the way that both of you have talked about. One of the other concerns I have is that we are talking about reform, but invariably we come back to wanting to use our current programs as a model or a basis for expansion. And as several of you actually have pointed out, we currently face the crisis of SGR every year. The complaints that we get from both Medicare and Medicaid from the provider community continue to grow. And to anticipate we're going to dump 47 million people into government programs that already have their problems without structurally reforming those programs, I think is not feasible. Now, we talk in terms of being able to save a half or whatever of the ultimate cost to pay for this expanded coverage from efficiencies within the current system, but then that means there's another half that comes on top of that. Mr. Levine, I also have a concern of, for lack of a better term, the woodworking effect. We recognize that there's always a woodworking effect of once you have coverage of expanding the utilization. Do you have a concern about that?
Thank you, Mr. Deal. I would think that anything that we do to expand government programs can potentially have the unintended consequence of allowing people the opportunity to leave their private coverage and come into the public program. And, you know, the difficulty from the state's perspective as it relates to Medicaid is if that starts to occur, if you see Medicaid rolls increase dramatically, we can't serve the population we have now. Providers, because of the rates paid in Medicaid, it's very difficult to get specialists and even primary care. So I would be concerned about the what we call the crowd out. So I think states really need to be consulted on that before that decision is made.
Dr. Williamson, you mentioned the question of defensive medicine practices and the necessity for medical malpractice reform. Dr. Gawande, do you agree that that's an element that ought to be addressed in this overall discussion?
I've actually written a great deal about what I consider to be a problematic medical malpractice system. It doesn't work for patients, it doesn't work for doctors, and it's excessively costly. One of the most, from some of the research work we've done, though, the most valuable thing we could do for malpractice is have universal coverage. Other countries that have universal coverage have markedly lower malpractice costs, primarily because the payouts for the medical costs are no longer in the legal system, and that is the majority of what is paid out in the costs. So physicians could have a markedly reduced premium for their malpractice expenses in a universal coverage system, simply because that system now guarantees the coverage for universal coverage, and it doesn't end up in that legal expense.
I don't quite follow the logic of that. Would you allow me to see if you could explain?
Yeah,
Let me say from the perspective of what I just heard you say, is that if we get more people into the public system, that the doctors don't need to worry as much about the cost of medical malpractice. It would seem to me that they would have even exponentially more reason to worry about it.
So if I get sued and I have to pay $1 million for a malpractice suit, most of that money is future medical expenses for the patient who was harmed and left disabled. In other systems, because that person's disability and their medical expenses are covered in a national health system, that doesn't enter the court system. And so the costs for medical malpractice are massively lower, much lower than you would achieve with a cap, much lower than other kinds of approaches. And a universal coverage system is hugely, hugely beneficial for us as physicians in helping decrease that malpractice cost.
That would require some substantial changes of state and perhaps federal law as well, I think, to be able to discount the cost of future medical as a compensable factor in medical malpractice.
It's just that every other country that has a universal coverage system is able to do that because they have health coverage.
Okay, thank you.
Ms. Christensen?
Thank you, Mr. Chairman. Mr. Levine, I clearly support Medicaid, and like the chairman, consider that building upon Medicaid, SCHIP, and others as part of extending coverage. But I do share some of your concerns about the ineffectiveness of the care and the poor outcomes. But don't you think we can fix Medicaid without throwing the baby out with the bathwater? I mean, there are other factors like lack of providers, facilities, services in poor neighborhoods.
I agree with you. I'm not suggesting necessarily throwing the system out, but what I am saying is that expanding it without fixing it will be perilous for us. I'll tell you, I look for instance, in California. When California implemented the coordinated care model, and they allowed consumers to opt out of the fee-for-service system into a managed Medicaid model unique to California, the rate of avoidable hospital admissions for African Americans decreased by 36%. Hispanics by 37%. When we talk about proving out prevention, and because what went along with that was looking at, for instance, in New York, cervical cancer screenings went from 39% to 71% using a coordinated care model. Diabetes testing went from 32% to 76%. What you find when you move towards a coordinated model is, and you reform it in the way I'm talking, you will spend more on physician, particularly primary care physician services. You will spend more on pharmaceuticals for things like diabetes maintenance drugs and things like that. You will spend much less on institutional services that cost more. And that data is out there. There is compelling data over 20 years to support that claim. So I think that fundamentally, before you look at any expansion into public programs, into public fee-for-service programs, I would argue that you should fix the structure so that it does three things. Number one, it's geared towards risk adjustment of premiums, so that if somebody's chronically ill, there's more resources that follow them. Number two, it also incentivizes people to identify people with chronic conditions. And it also encourages chronic disease management. And then finally, engaging the consumer in their own behavior, particularly if they have a chronic disease.
Thanks. I'm going to try to get two more questions. And thank you for the clarification and points. Dr. Gawande, you mentioned as one of the reasons for having the problems within the system that decision-making not being as consistent or reliable as people deserve. Now, in looking at that decision-making problem, have you seen any racial, ethnic, economic, or gender basis for this, or is it across all lines?
No, and just as Mr. Levine pointed out, the ways in which the insurance coverage plays in affects the disparities in the care, and then also in the decision-making that occurs. And we've seen some very powerful studies that show, for example, that people presenting with the same complaints about chest pain end up having very different care. One of the striking things from being able to implement our work in making surgery safer is we've done it from rural Tanzania to top hospitals in places like Seattle. And the striking thing is that you're taking places that are hugely disparate, and even with that degree of resource changes, we were able to reduce their complication rates and bring them all up the bell curve and reduce the disparities considerably. And if we can do that from India and Tanzania and Jordan to London and Toronto and Seattle, we can do that between my hometown in rural Ohio and a place like here in D.C.
Thank you. Dr. Williamson, could you elaborate on your statement in your testimony that you caution us not to overestimate the savings from advances in health information technology?
Yes, I can. That's made purely from a perspective of a practicing physician. I was one of the first 4% of physicians in Georgia to implement an electronic health record as well as electronic billing services. And that one item was the single largest purchase in my practice's 25-year history. And maintaining it is enormously expensive every month. Once you buy it, you've got it. Changing is prohibitive. So you're pretty much locked into a certain cost of maintenance month by month. It is a fantastic tool, and it allows you to do things that you simply cannot do otherwise. Unfortunately, saving money is not one of the immediate advantages that I have found. Now, I know many practicing physicians that have bought systems like this and actually abandoned them and just called it a loss. I know other physicians that feel like it has added to the productivity of their office. It's not a slam dunk, though, and it shouldn't be, I don't feel, viewed as a way to instantly save money across the board. The other concerns that I have about health information technology going forward, although certainly it could make us more efficient, is that protecting patient privacy be paramount in that, because a patient is much less likely to come to the doctor if they know that their medical records are instantly going to be on the internet somewhere. And we've got to keep that in mind going forward. Is talking about something that would keep patients out of the doctor's office, that definitely would. So I strongly encourage you to keep that in mind as we go forward, protecting patient privacy. And health information technology.
Thank you, Mr. Chairman. I'd like to just ask unanimous consent to enter a statement for the record submitted by AARP for this hearing.
We've seen it, so without objection, so ordered.
Thank you.
Mr. Burgess.
Mr. Chairman, before I do questions, may I just take a moment for a point of personal privilege? I wanted to add to your optimism after Dr. Gawande testified, and he gave you great hope. I have a young constituent here from Denton, Texas, Wen Chen, who's a student at the Texas Academy of Math and Sciences at the University of North Texas. This is where young high school students are taken into a college environment and allowed to flourish. And Mr. Chen has done exactly that, and he's developed a new system called pulse plasma deposition, which lays down a layer on plastic, silicone, metal, and a variety of other substances which inhibits the growth of bacteria and therefore could one day reduce our hospital-acquired infections with a very inexpensive process that he's developed. So, Mr. Chen, stand up and take a bow. He's now, as I understand it, he's won a scholarship from Siemens Westinghouse for $100,000, and he's a finalist for an Intel scholarship. So congratulations. And there, I wanted to add to your sense of optimism that there are indeed new breakthroughs on the horizon that are not going to break the bank. Thank you, Mr. Chen, for your indulgence. Now, I'm going to ask you a question. This is really mean to do it, but I'm going to do it anyway because I've been sitting here all day. And you don't have to answer, but let me just go across the board here. And if you have health insurance today, would you swap that one-for-one for Medicaid coverage? Mr. Ebler?
I'm in a policy box here because I'm representing the IOM committee, and we did not speak to that. So my only advice to you is that health insurance coverage matters. It's important for everybody to have it. We have no judgment on that question.
All right. Very good evasive answer. Mr. Levine?
Would I trade my coverage for Medicaid?
Yes.
No.
Dr. Williamson?
No.
Dr. Gawande? And the reason I ask this is I offered an amendment during the SCHIP legislation so that members of Congress could get a better idea. And Mr. Levine, you've alluded to it. The provider rates are different in Medicaid. Of course, it varies from state to state, and it may be different in different states, but it's typically hard to find a doctor if you pick up the phone and call and say, will you take my Medicaid? And then, of course, for the doctors who do, it's very difficult if you need a cardiologist or an ear, nose, and throat specialist or whatever. It's hard to find a specialist to take that care. So I offered an amendment to get members of Congress to give up the FEHBP, the Federal Employee Health Benefit Plan, and switch to Medicaid so we could live that life for a while and see if we couldn't be more creative about offering better solutions, and I didn't get any votes. So just like you all, I mean, you're not unique in that, but I didn't poll the IOM, and maybe next time I need to do that. Now, Ms. Levin, you've brought up some very interesting concepts about Medicare, being just simply a bill-paying organization, and therefore the overhead, when we hear overhead comparisons between Medicare and other private sector plans, that is perhaps a false comparison. And we also all know that we never calculate the cost of capital. Medicare has a huge unfunded liability, and if any of us were to construct a business plan and carry a liability, we would have to have interest payments on that liability going forward. But would you care to speak to that just a little bit more?
Well, there's a couple of things. I think two things. First, about the administrative costs of Medicare and Medicaid, and then two, relating to rates. Let me answer the second part first. You talked about rates. Let's be clear about how Medicaid sets rates. It's different from Medicare. Medicaid sets rates based on how much a state can afford generally in the aggregate, and there's no rationale behind the rates. If you're a neurosurgeon in Lake Charles, Louisiana, and you're a neurosurgeon in Baton Rouge, you're getting paid 90% of Medicare, and by the way, I understand that's a pretty good rate compared to other states.
Very good.
So come to Louisiana if you're a doctor, but irrespective of the market conditions, we pay the same thing. That is not a way to deal with the shortages that we have. And in fact, I have a case right now, a woman with a brain tumor that literally was told by a primary care doctor who lives in Lake Charles, you have a brain tumor. There's no neurosurgeons taking new Medicaid patients. Drive to Shreveport, go to the ER, tell them you have a brain tumor, and you will get to a neurosurgeon. That's how Medicaid operates, and there's stories like that in every single state. So it's not a unique anecdote. As to the administrative costs, understand, and I'm going to refer to the American Medical Association. They've done their own analyses of administrative costs between public and private programs. First of all, when you measure the administrative costs of Medicare and Medicaid, fundamentally all they're really doing is paying claims and then chasing the claims afterwards when they go after fraud and abuse and overbilling. But they don't even count administrative costs the same. In the Medicare program, of course, this is according to the AMA. Premium collections by private payers is counted, but not by the government when they count their own administrative costs. Medicare outreach, customer service, OIG auditing, contract negotiations, these things are not added the same. And then what administrative costs also don't count in the public paying systems is, you're talking, like for instance in Medicaid, people that are very sick, very chronic, that are in the Medicaid fee-for-service program, as a percentage, if you're measuring the cost as a percentage, of course they're going to be lower because the per unit billing, the per person cost is substantially higher.
Okay. Let me just ask you, I need to move on to one other thing. GAO did a report 2 years ago that suggested within the Medicaid system that Medicaid becomes the primary payer when in fact it should be the secondary payer, and this occurs roughly 15% of the time, different in different states, as low as 11% in Texas, 25% in Iowa. Is there, and I suspect this is a problem because of the difficulty with collecting across state lines if a patient changes addresses and changes locations. Is there a way that we can deal with that problem of Medicaid going from a secondary insurance to a primary insurance when a private insurance should in fact be covering that patient?
We do have recruitment processes, but typically, again, as I mentioned earlier, we're paying and then chasing afterwards. I need to do some more research on that for you.
I'll get you the link to the GAO report, and I'd be interested in your thoughts on that. Thank you, Mr. Chairman. I'll yield back.
Thank you. Ms. Capps.
Thank you, Mr. Chairman, and thank you to these witnesses and for your perseverance and staying as long as you have. I want to divide my time and turn first to Dr. Gawande and then Mr. Ebeler for the last half of my precious 5 minutes. Dr. Gawande, I appreciated your testimony very much, as I told you, and I'm very interested to learn more about your idea for a National Institute for Healthcare Delivery. As we develop a strategy to improve our health system overall in that big picture, clearly clinicians are the most integral players. And I would like to ask how you foresee a National Institute for Healthcare Delivery or something like that working, and how we could get that information to clinicians, how actually you would see that implemented.
So a good example would be to break down our services that we provide into several buckets. We do 3.5 billion prescriptions. We do about a billion office visits. We do 120 million ER visits. And if you had a National Institute of Healthcare Delivery, they would focus on asking, why do the ERs not work? What are the tools they need to get rid of diversion, to deal with organizational problems, to stop the waiting times in ERs, to divert the group who are getting non-urgent care but should be in other places? They would invest in programs that we don't invest in, for example, experiments with how do you triage people correctly so they go to the right place safely and get quality care and save money. NIH does not pay for that work. I spent 3 years trying to say that we know how to make surgery have fewer complications, but there was no funding in the government to get it. I got the funding to carry out an American study from the World Health Organization. In the end, it only took about $100,000. I made sure we tested it in 8 countries, and I showed here at home that we could reduce our complications with a 90-second checklist that cost nothing at all. And so that's the kind of work I can imagine coming from a National Institutes for Healthcare Delivery, service by service in the ER, in dialysis, in operating rooms, and in offices and clinics. What is it we need to make those places organize all of these drugs and technologies we're trying to deliver?
Thank you very much. I think we need to follow up, or at least I would like to follow up with that. Mr. Ebeler, some of the testimony that's come forward today during this hearing argues that we should look at private arrangements, well, that's sort of sacred physician-patient relationship in the private context. Or others have argued that our healthcare problems can be solved through a tax code alone. In other words, leave those decisions in that other sector. Your research seems to indicate another direction. And maybe you would elaborate on why this might not work according to some studies that you have access to.
Whoops. Let me say what we found, and it's not, we're not speaking particularly to different options that the subcommittee and committee have for reforming system.
Right.
Our message and our research really hones in on the fact that people who have no coverage are getting less than they need. They're suffering worse outcomes. And that it relates to, a little bit to Mr. Deal's question. Very good research that when you add coverage, whether that be children becoming eligible for CHIP or adults becoming eligible for Medicare, for folks who are previously uninsured, you see very positive results of that. So that is the way to go. So the message we have for you is the need to proceed, need to make sure that those uninsured patients get coverage so that they can have a connection with a physician. The flavor of that approach of the different options in front of you, we don't have a view on that at this point.
Your basic discovery, if you will, it sort of makes sense too, that if you don't have a regular path to some provider that you use for small things, that then when you are forced because of the drastic nature of your symptoms to seek health care, you're not going to have as good an outcome. And you have documentation to show that's true. So which kind of care it is that we pursue with some kind of goal of everybody getting coverage some way, is it less important to you than the difference between not having coverage and having coverage?
Correct.
Or access to non-access.
That's
anyone else? I have 16 seconds left. If anyone has a final thought on that topic. I appreciate that very much. I think it gives us a good starting basis from which to, I hope we can all agree as a result of this day that we've spent with you that it's more important to have some access to care than not to have any, even though there is care available in the community.
That's an important point, because these studies, the simple reality is the uninsured are getting some care.
Sure.
And there's a safety net out there. There's doctors and nurses and hospitals trying to help every day. But the simple reality is when you adjust for all the things you need to adjust for, they're not getting the clinically appropriate care and they're suffering worse outcomes.
I yield back. Thank you very much.
Thank you, Mr. Gingrey.
Mr. Chairman, thank you. And I'll direct my first question to Dr. Gawande. Dr. Gawande, when Ranking Member Deal was talking to you about medical malpractice and that sort of thing, and you were saying under universal coverage, it would be much less expensive. When you reference universal coverage, were you meaning the same thing as this phrase, National Institute for Healthcare Delivery? Is that basically the model that you were talking about?
No, so a National Institute for Healthcare Delivery would be more like a research organization like we have with the National Institutes of Health, which does new discovery of technologies, and this looks at the side of how do we make sure those, how do we...
Yeah, oh, okay, then I understand that, but,
Yeah.
but basically I guess then you were referring to, when you said universal coverage, you were referring to universal health care, a single payer system.
No, that's not true. Any system in which, so for example, in Switzerland, they don't have a single-payer system. They have multiple private insurers that provide coverage for their entire population. They don't have a public insurance program.
Reclaim my time. The reason I asked you that question, because I really do believe that a lot of people get confused about universal coverage and universal health care. And I think it's important to understand that members on this side of the aisle and even on the other side of the aisle, we're in favor of universal coverage without question. I think those 47 million people ought to be insured, and I think that would be good for our country, good for our economy, and certainly good for them, the individuals. But universal health care, when it means a single-payer system or national health insurance program. And I think that was the thing that seemed to be a little bit confusing when Representative Deal was asking you about the cost of malpractice coverage, and he was a little confused. And clearly, I think it would not be cheaper just because you had universal coverage.
No.
But anyway, I'm going to move away from that. I wanted to ask the other witnesses a couple of questions real quickly for Mr. Levine. In regard, you run that Medicaid system in Louisiana. Do you feel that we should get away from the Medicaid system and very likely put everybody in a managed care Medicaid sort of program, maybe through a connector where you have insurance companies that are going to bid on this business?
I'm for consumers having a choice of what model they want. I think it's very difficult for states. I mean, we process 54 million claims a year. We spend a lot of our time just really chasing fires as opposed to trying to put these integrated systems together that we need to. There's a variety of different models out there. I think philosophically where we're at is a coordinated system of care where consumers can choose from different networks which network they want based on transparent outcomes, which one has the best patient satisfaction, which one has the best provider satisfaction, best compliance with well-child checkups, and let a consumer choose that plan that works best for them. I think in that model, the consumers win because fundamentally everyone's going to react to the most powerful force out there, which is...
Well, reclaim my time because I do want to get to my colleague from Georgia with the last question, but I tend to agree with you on that, Mr. Levine. Dr. Williamson, I thank you for your testimony. And, you know, like every aspect of our economy, health care and its costs are also a function of supply and demand. I think you brought that out in your testimony. And obviously, when we're discussing our health care system, demand is the need for medical services by the patients, and supply is very much contingent on the quality and quantity of doctors and other medical providers in the market. I'm wondering if you can tell us, from your perspective, what obstacles potential medical students of the future may face when considering entering the field of medicine. I'm talking about education costs, years of schooling, cost of liability insurance, and practice overhead. If you could, in the few seconds remaining.
It is a significant endeavor to start down that road, and you just listed, I think, all the major items. Students, as you know, now face enormous debt when they finish medical school. The numbers are way into six figures. I've heard a lot of figures thrown around, but that amount of money is easily equal to a mortgage, easily. And I remember when I first finished residency, I felt like I should be looking for a retirement community rather than a job, but I had to go out and find a job. And that basically is a starting over point for residents that finish their training after a 13-year or so, depending on what specialty you're in, tenure. And you've accumulated quite a lot of debt, made very little money, and spent a decade and a half. And I'm concerned that bright young men and women, like the gentleman that was introduced so eloquently earlier, aren't going to pursue the profession of medicine if they don't see it as a viable way to take care of their families and their debts. And that's a very real problem that we have now. And it's not just attracting bright young men and women to the field, but it's keeping them. It's like if
real quickly, because my time has run out, do you feel like if we go to a single-payer system, national health insurance, and that these young, bright men and women realize that they indeed will be working not managed by the government but for the government, that would disincentivize them even further from choosing medicine as a profession?
I believe that's correct, and we have data in Georgia that bears that out. We have survey data that practicing physicians have said in a majority that they do not feel that increased government involvement in financing health care is going to be a good thing for the profession. So I think you're right. I think a larger government involvement in health care in general is going to dissuade bright young men and women from entering the field of medicine.
Thank you, Doctor.
Thank you. Mr. Sarbanes.
Thank you, Mr. Chairman. Thank you to the panel. Dr. Gawande, I have to say your response to the malpractice question was kind of like a heat-seeking missile. I thought that was very good. I'm sure it's going to generate a lot of follow-up research and inquiry. But I wanted to ask another question because I'm so focused on this issue of the physician shortage, particularly in the primary care arena. And also how it gets linked to just new and more innovative delivery models, or taking some of the existing delivery models that we have and expanding them. And the term I use for this is sort of place-based healthcare. So, for example, school-based health clinics. That's where the kids are. That's where they spend most of their day. There should be a health center in every school, and you're going to need pediatricians to staff those. There's a concept called naturally occurring retirement communities, which are where people are aging in place in certain neighborhoods. So you can look at the whole neighborhood like you would look at a senior living community. And so you could argue that a place-based clinic with an emphasis on geriatricians in a NORC, and a naturally occurring retirement community, would make sense. The concept of clinics in places of employment. I mean, if you walk down the hall, there's a health clinic, you know, a health suite right down the hall here, to make it easy for people who work here on the Hill to go get health care. So I don't know how much you've thought about that, but I'd love to get your perspective on that in terms of informing the kind of delivery model we're trying to move towards, and where you would base a lot of these new primary care providers, like geriatricians and pediatricians and others, once we get them in the pipeline.
My immediate reaction is that what you're honing in on is that we've had half a century now of lost innovation with how primary care is created and delivered, because we haven't provided the incentives for people to put them anywhere else other than in offices that might be from 9 to 5 with very limited evening hours, very limited weekend access, and so on. The idea of putting them in places closer to where people actually need their care, if there was more incentive for those physicians to be entrepreneurial, it would be, you would see those cropping up, and you would see that come into place. I think the creation of ideas like medical homes starts to give people incentives for organizing their groups in places where they can do that work most effectively and get to their patients that they're looking for. And so I think that's an important point. The second thing is that on physician shortage, your earlier comments and then coming again here to say that we have this looming aging population without adequate primary care, and then a world where if we create universal coverage, will provide increased demand for basic services. We've seen that in Massachusetts, where we have coverage now and primary care physicians finally can see people, but because there weren't enough primary care physicians around, we still have insured people, as the chairman mentioned, going to emergency rooms. And so I think that work that you're interested in is very fundamental.
Well, and of course, that'll be the critique, right? If you get the coverage and you don't have the providers in place, then people are going to have to wait, you know, weeks and months to see somebody. And that's the refrain you get from those who don't want us to move to coverage in the first place.
It's a chicken and the egg problem.
Yeah.
You can't create those physicians sitting there with their offices open without knowing whether there are going to be people coming. And you see it in plenty of places that expand coverage, that you see a growth in those models. But what you're going to have happen over time is that we also have to learn how to take care of an enormously growing aging population. We're going to double the number of people over 65 in the next 20 years, and our health workforce isn't going to grow much to keep up with that, no matter what we do. And so our models have to evolve. An example is that at Intermountain Healthcare in Utah, Brent James, who leads that program, was able to take care of their entire diabetic population with just 2 endocrinologists by being creative, and they're getting better quality results than almost anywhere in the country.
The concept of medical home is one that we typically think of in terms of an individual. But I think what we're also discussing here is the potential to think of a medical home for a community. And that's what a clinic in a school is. It's a medical home for that school community. It's what a clinic in a naturally occurring retirement community is, that has a staff of geriatricians is. It's a medical home for that community. So we can look at it both in terms of the individual and in terms of the community. Thanks.
Thank you. Ms. Schakowsky?
Thank you, Mr. Chairman. I think the need in this discussion as we go forward in time to use accurate data is going to be very important. I talked about the myth that I think Mr. Is it Ebler or Ebler? Ebler has talked about in his studies, that there's a difference between getting access to care and then getting access to care you need. You can go to an emergency room, but obviously insurance is very important. And this notion that somehow we have absolutely the best care system in the world and no one in the United States goes without health care really begs the question of the negative effects of not having insurance. That's one myth. We also need to talk about Canada. If you ask the question, would Canadians swap with the United States on their health care system? I think we should get that data about what's really going on in a country that is pretty satisfied with their health care. And finally, the issue of students not wanting to go into health care if there were a national system. I've talked to plenty of doctors who say not having to deal with billing and if we had a really good system of public health, that it would be more satisfying. But what I wanted to ask Mr. Ebler, a previous IOM studies found that the lack of insurance resulted in 18,000 premature deaths annually in the United States. I'm wondering if you have updated that at all, or how your new study contradicts the notion that we're all accessing the care we need.
Thank you. The report I'm presenting today is a sort of an update of a very extensive six-part IOM series that was presented between 2001 and 2004. We did not update that particular study on 18,000 deaths. We did, again, look at the literature very clearly, and the evidence is even better than was available to that committee when it met. That it absolutely does matter to have health insurance. It matters for the access of children and adults, and it matters for the health outcomes. And the likelihood of premature death is higher for those who have no health insurance. We didn't follow up and quantify that, though.
Mr. Chairman, is the report, the Institute of Medicine study, has that been inserted into the record, Mr. Chairman? Has the, or at least the report brief, has the Institute of Medicine study been put into the record already? If not, I'd like to.
I'm a little concerned about the number of pages.
Well, how about the report brief?
Yeah, that's fine. We'll put
okay,
that
I would, with unanimous.
without objection,
okay.
so ordered.
All right, I also wanted to ask Dr. Levine. Is it Levine or Levine? Levine? You accept either?
Either one, ma'am.
Okay. I was interested in your statement and agree with much of it. But you said that Medicare and Medicaid are not innovators in quality, and you mentioned the importance of medical home model, which I support. In Illinois, we began the primary care case management medical home initiative in the fall of 2006. We've enrolled 1.6 million Medicaid and S-CHIP beneficiaries in 5,300 medical homes. And a May 2008 memo from the National Academy for State Health Policy mentions medical home models in Pennsylvania and Arizona. I think there were other states, I think including Mississippi, and they're doing well. And by the way, that memo also talks about state Medicaid innovation in health IT. So Louisiana could undertake similar initiatives, could it not?
Well, in fact, Louisiana is doing a lot of those things. We have a primary care case management program where 800,000 of our residents that are in Medicaid have we pay an enhanced fee to the primary care doctor, $3 per member per month. And frankly, our results haven't been, in some instances, have been good in terms of reducing ER visits. But when you compare us with the national HEDIS measures with other states, we perform poorly. And so we're looking to improve that system. We have 37, I believe, medical homes that were just certified by the NCQA just last week. That's true. And I think we're the second state in the country to have a hospital certified as a hospital-based medical home. So, you know, we're embarking on that. You know, we're a state that has 23% of our children are in poverty. You know, we're a state that I think is still going through rebuilding from 2 hurricanes in 2005 and now again 2 more in 2008. And so we're engaged, and we have submitted a waiver request to CMS to allow us to dramatically transform our Medicaid program to get to what you're talking about, allowing consumers to choose between different coordinated care networks. And we're still going through what the complexion of those networks will look like, but at the end of the day, and I think the doctor said it right, he said we shouldn't stop with a discussion about the medical home. You really have to consider the neighborhood. You got to have specialists. You have to have institutional support. You have to have home-based services. So I think that is the model, and I think Medicaid's programs all over the country are going to have to transform to that model.
Thank you.
Before I go on to the next member, we've entered a number of executive summaries here, and I've got one more. This is the economic impact of private practice physician offices in Georgia. I'm going to put in the executive summary and then reference the website for the full document. I'm going to do that with each of the ones that we've had today. And then, in addition to that, your article, Dr. Gawande, from the New Yorker, Getting There From Here, How Should Obama Reform Health Care? I'd ask unanimous consent to put that in the Georgia document. Without objection, so ordered. And next is Ms. Castor.
Thank you, Mr. Chairman. Thank you, gentlemen, very much for your testimony. The healthcare in America is such a patchwork. You know, you have Medicaid for folks in poverty, primarily children and pregnant women, then Medicare if you're 65 and over, but sometimes seniors, sometimes nursing home under Medicaid and Medicare, and then the S-CHIP, and private health insurance is the bulk of it, of course, but Mr. Ebler, in your testimony, you point out it's practically impossible for a hard-working family now to access insurance if they don't get it through their employer, and they're working hard, so they're not going to qualify for Medicaid. They're too young for Medicare. And I think the latest estimates for a family, it would cost over $12,000 a year to access it, and that's if they don't have pre-existing conditions. If they do, they'll meet the hand. In my community in Tampa, Florida, in Hillsborough County, we have a model program that we set up over a decade ago, and to kind of fill those gaps for folks that don't have health insurance from any other source. And I think it's one of those models that we need to be looking at, and then I'm going to ask if you all can identify other models from around the country. What the Hillsborough Health Care Plan does is kind of like what Mr. Sarbanes was discussing and Congresswoman Capps, a more expansive community clinic system. Not just community health centers, but they're an important piece of it. We've developed a neighborhood clinic system in conjunction with our hospitals and doctors, private hospitals and private doctors that do this, because a decade ago, we were just having our lunch eaten with property taxes going to indigent care in the hospitals. So instead, we said, let's get these folks out of the ER and into neighborhood clinics. It has worked very well, and we're able now, we've built in programs like smoking cessation and prevention, and they have that medical home in their neighborhood. It might not be as close as members of Congress have right down the hall, but they recognize the doctor, they recognize the nurses in their community, they're part of their community, they're their neighbors. Can you all identify other models like this? And Mr. Levine, you're familiar with this because of your experience in Florida. Is this something that a model we should be looking at, and can you identify other models across the country where we should focus in and learn some lessons?
May I think, first of all, I'm familiar with the Hillsborough Health Plan. As you might know, I used to run South Bay Hospital and Sun City Center. And so, and they operate it as an insurance plan. Basically, once you meet qualifications, you effectively have a medical home. And it does operate well for the people that fall through the cracks and don't have other forms of coverage, whether they're Medicaid or private coverage. Healthy Palm Beaches is another one that operates. They offer they actually offer an S-chip insurance plan. As you know, almost every child in Florida is covered through every child in S-chip in Florida is covered through private insurance, and Healthy Palm Beaches is operated as a private insurance plan, even though it's a public plan. The North Carolina model is a medical home model that seems to be working well in North Carolina. Arizona uses models. There's 40 states that are using different variations of integration of care. There's all the way from straight managed Medicaid all the way to various forms of enhanced primary care case management. And I think each state related to Medicaid has to do what works for that state. And really what drives that is the provider community. What does your provider network look like? How robust is it? And can your model work? But I think there might be other people that can answer other models as well.
I'm actually familiar with Hillsborough. I used to work at the Robert Wood Johnson Foundation, which
yes,
helped.
and the Robert Wood Johnson Foundation recognized the.
Yes. Let me just sort of talk about it briefly from the perspective, again, from the relatively constrained lane I'm in from the committee. And it reminds me a little bit of the lexicon issue that Mr. Gingrey raised. When people hear everybody covered or universal coverage, from the perspective of our report, that's an open issue of how one achieves that. So these different models of how one gets to everybody getting coverage is the key variable that we're here reporting to. The second thing is the models you're describing connect to another piece of our recommendation, and I think what many committee members have been discussing, which is you can't, everything relates to everything. You can't get to coverage without costs, which is why we've recommended action on both. But you can't get to cost without attention to delivery. You can't get to delivery without quality. You can't get to those two without primary care. So the idea of looking at models that do, and not just coverage, but other approaches to reforming delivery, producing the high-performance system that you're talking about are a very positive direction to go.
Thank you.
Thank you. Mr. Scalise.
Thank you, Mr. Chairman. Appreciate extending the courtesy. As we discuss the importance of health care reform, obviously there are a lot of different options, a lot of different ways we can go, and I'm sure on this committee there's going to be a whole lot of discussion on what the different routes are. I know I've got some real concerns about a socialized health care model, and I think we've heard some of the problems with Medicaid specifically and how just spending money doesn't necessarily yield better health outcomes. And if Secretary Levine, if you can touch on the medical home model that Louisiana is pursuing and how this provides more options for people on Medicaid to maybe use the money smarter, in essence, to yield better health outcomes with the money that is being spent.
Louisiana faces a problem not unique. It's faced by almost every state, and that is, first, in 2004, our Medicaid budget was 10% of our state budget. Now it's 22% of our state budget just 5 years later. And so we clearly have to do something to maintain the sustainability of Medicaid. And so we started looking at the cost of our program. We realized that we need to focus our effort on, number one, early identification of people with chronic conditions so that we can properly manage the condition before it becomes acute and we wind up spending money. Our state has the highest rate of avoidable hospitalizations in the United States, which is one of the drivers for why we have such an expensive system with poor outcomes. So our proposal, which we have submitted to CMS, creates a medical home model. Everybody in Medicaid would have a patient-centered, NCQA certified, eventually medical home. We actually require the coordinated care networks to share any bottom line results. If there's a positive bottom line at the end of the year related to the coordinated care network, they must share the savings with the primary care physicians. That's something that I don't know that any other state is doing right now. So there's some very unique tenets to our proposal we'd ask people to look at, and we certainly are going to try to get CMS to approve it.
How long has it been, the application that CMS is?
The application was submitted in December, end of December, and there has not been any action, formal action by CMS yet. I anticipate, because of the transition, that it might speed up once there's a secretary and an administrator in place.
Yeah. What I would urge CMS to approve that application.
Just briefly, at the risk of defending Medicaid, again, our view of this is no coverage is the wrong amount. One wants to move to coverage. And we are open about the various tools at your disposal to do that, one of which is Medicaid, one of which is improving Medicaid. And I guess the only thing I would point out is that sort of if we were a random draw of 5 males at this table from the community, it's likely that one of us would be uninsured. And the choice of no coverage in Medicaid might be viewed differently than the currently insured. So it is again, the IOM report has no particular policy option that's preferred. My only message is to urge you to keep various options on the table as you deliberate and make your choice.
Right, and I think earlier when everybody was asked to go down the table and respond to whether or not you would be willing to trade your health policy for Medicaid, and nobody responded that they want to do it. I think that said a lot about the problems, but I will say, you know, we've experienced this in Medicaid populations, not just in Louisiana, but you've seen a shrinking number of doctors that accept Medicaid patients because of some of those problems. And as especially with this last S-chip bill, I think a concern a lot of us had was that as you go to a much higher level of bringing more people in that otherwise in some cases are on private insurance, because the lure might sound good that you're paying for private insurance now, you can get on S-chip and you don't have to pay. Many of those people are experiencing that many doctors don't take Medicaid, and so you get a decreased list of options as a parent now. And I'd be curious to hear your take, Dr. Levine, about the problems with Medicaid. Is we're talking about physicians. We want to attract more physicians, and there are big challenges in getting enough doctors, people to come into the profession. If it looks like we're doing something, creating policies that replicate more of a Medicaid model, how would that help attract more doctors when in fact many doctors don't want to take Medicaid today?
I think any model, particularly in Medicaid, historically Medicaid has achieved its financial goals by pushing down provider rates. That's pretty much the only weapon we have to try to fight the growth in Medicaid. And as we've done that, it's been a self-inflicted wound in that we wind up with fewer, particularly specialists, that will take new Medicaid patients, and then that creates a serious access problem, and obviously it drives ER utilization. We know what the consequences are. And I think the problem is the spiral that we're in is if we don't, if we expand Medicaid, if we use Medicaid as the vehicle by which we expand access to coverage, and we call that a victory, we have not solved this problem. We have given people a card for a system that may not be able to serve their needs.
And we may, in fact, have made it worse, and I know my time has expired, but I appreciate your comments, and hopefully we can get CMS to approve that application, the waiver. Thank you, Mr. Chairman.
Thank you. We're done with our questioning, but I want to thank all of you. Now, you may get additional questions, in writing from us over the next few days, so we'd appreciate your getting back to us about that. But again, this was our first hearing today, and I appreciate your participation. And obviously, we have a long way to go, but we're determined to deal with this issue of health care reform. So thank you again, and without objection, this meeting of the subcommittee is adjourned.